final session today, we'll be welcoming Dr. Neelam Giri and Dr. Khavandgar from the National Institute of Health. Dr. Giri is a senior research physician at the National Cancer Institute. She leads the studies on inherited bone marrow failure syndromes, including Fanconi anemia. She also directs the Fanconi cancer screening study to improve early detection and care. Dr. Khavandgar is a staff clinician at the National Institute of Dental and Craniofacial Research and specializes in oral maxillofacial pathology, including conditions that affect people with the rare diseases. Please give them a warm welcome.
Thank you, Michelle. It's very difficult to follow after Annika and Christine because we are not going to exercise, we are not going to jump around, and we are going to talk about serious things. So, bear with us. Anyway, so we are here, myself, Neelam Giri, and Dr. Khavandgar, along with the rest of our team members, and you can stand up, Dr. Lisa McRonalds, Margarita, Emily, whom you have heard yesterday, and Michelle. So Lisa McRonalds is a principal investigator with me. Margarita and Michelle are the nurse practitioners who are the primary contact with people who are in the study, so they get to know them very well. And Emily meets with people to discuss their psychosocial needs and distress level. So we are going to talk about Fanconi anemia cancer screening study at NIH. We started this study about 2.5 years ago in 2023 because we wanted to develop a comprehensive program to screen for the type of cancers that people with Fanconi develop. So we wanted to establish a central place where people can come on a regular basis. We know that there are some centers where people are already getting evaluated, but not everyone gets everything done everywhere. So we wanted to encompass all that and bring it to one place so that we can do it on a regular basis and follow people regularly so that we can find changes early and recommend treatment in discussion with others. As you have heard from our German speakers, they have been doing the study for oral mucosa to detect cancer early for a long time, but they are coming from Germany and they cannot continuously follow you. So we incorporated that study in our cancer screening program in collaboration with them so that we can develop it over here also and do the same things that they have been doing so that people don't have to wait for them to come all the time. This is the study of oral mucosa to detect cancer early by regular exam, documentation, brush biopsy, by diagnosis under microscope and DNA ploidy study. And also to screen for other types of cancers that can occur in people, like esophageal cancer, cancers of anal and genital areas, breast cancer in women, liver cancer, and skin cancers. And because it's a study at NIH, and it's a research study, we collect a lot of biospecimen, we collaborate with a lot of institutions, and this study is funded by the Fanconi Cancer Foundation. Our collaborators include the German team, of course, the British Columbia Cancer Center team, and the Rockefeller team with Agatha and Tamar. As I mentioned, the study opened about 2.5 years ago, and we plan to enroll about 200 individuals on this study over a period of 5 years and follow each individual on a regular basis for about 10 years at least for cancer screening studies. The registration for the study is online, and you can go on the website, you can click on that and sign up for the study. It takes about 15 to 20 minutes. Those are the screening questions that we ask. Once people have signed up for the study, then we see it on our part, and so then we make people eligible, and after that, Margarita or Michelle, our research nurse practitioners, they contact the participants, they talk about our study in detail, get consents for the study, and then obtain some medical history. And after that, we have a meeting among ourselves, and we discuss the needs of the participants, discuss what screening has been ongoing, and then bringing them to the clinical center. At that time, our research nurse, These are lead through, and our research assistant get involved. They work with the participant to invite them to the clinical center and then plan out their clinic evaluations. It is a 3-day visit to the NIH Clinical Center. On the left side, you see the NIH Clinical Hospital where we see the people, and on the right side you can see Salidput and Delhi. So because the clinical center visit is for 3 days, people have to stay somewhere. So people who are 30 years and older get to stay at what is called Safra Lodge, which is within the NIH campus, and that's our primary location for adults. And anyone younger than 30 years of age gets to stay at Children's Inn. So only if we don't get accommodation in any of these two places, then we try to arrange hotel accommodation for people for the 3-day stay. Now, what are the screening investigations that people undergo at NIH? So it's a detailed history and examination by our team to their clinical status and their biological status. Based on that, anyone who has not undergone bone marrow transplantation also gets evaluated by bone marrow examination to find out the status of their hematological status and whether they need further management plan. Of course, skin examination needs to be done for everyone for screening for skin cancers. We generally take medical photography during the first visit. This is the photography of the whole body. The cancer screening includes examination by an ENT physician for oropharyngeal cancers, dental examination, and Zora will be talking about that in details. They get to see a GI physician who is also a hepatologist for the GI evaluations, and everyone who is older than 18 years of age gets upper GI endoscopy and, if needed, a colonoscopy. For the liver-related evaluations, they undergo ultrasound and they undergo a fibroscan of the liver on an annual basis. And then we have a special physician that does the anogenital examination. In addition to all these, during their first visit, people can have skeletal survey to look for any radiological abnormalities, bony abnormalities. Abdominal ultrasound is done to look for liver, kidney, spleen, and other structures during the first visit, and annual liver ultrasound. We also do DEXA scan every 3 to 5 years as needed for bone density and evaluation by endocrine if needed. And of course, women undergo annual breast MRI study for cancer screening of the breast. At the end of it, we provide a summary of all the clinic visit. We share all the reports with the participants. We send it to their physicians, including all the scans that we have done, and then we coordinate the management with the care team. Every 6 months, we send a follow-up reminder for completing the online follow-up screening, because generally we see people every 1 year. So in between what is going on, we would like to follow. So in addition to all these, if there are any special studies needed for people who have had history of cancer and need follow-ups, like a PET CT scan, MRI brain, if needed, we do that too. This is our entire team. On the upper side, the whole of upper side, and on the left side is the primary team, and then you have ENT physician, the GI team formed by Dr. Heller, a gynecologist, and of course our anal cancer screening team and cytopathologist. So I said that our study has been open for 2.5 years now. So far we have enrolled 92 people on the study. We have seen most of these people are adults. 70 people out of 92 are adults and 22 are younger than 18 years of age, but people that have come to NIH have mostly been adults, that is over 18 years of age. We have seen 40 people for a number of visits. The total visits that have happened so far is about 77, because some people have come multiple times. In addition to this, we do oral screening at the camp and at the adult meeting, as we have seen in that room. So what have we learned so far? And I'm just giving an overview, I'm not giving any details. If you want to know further details, you can follow poster number 12. But Out of the 40 people who have been seen at NIH in the past 2.5 years, we were able to detect cancer on screening studies in 5 individuals during screening. 2 of them had oral cancer, 1 had esophageal cancer, and 1 screening led to the diagnosis of breast cancer in 1. And 1 was diagnosed with myelodysplastic syndrome and referred for transplantation. So any patient who gets diagnosed with cancer on the study gets discussed at the Fanconi Cancer Foundation Virtual Tumor Board along with their primary team for planning of treatment guidelines. And that has been extremely helpful in developing treatment plan for individuals. Now I will give the microphone to Dr. Neelam Khavandgar, who will be talking about details of oral screening.
Okay, hi everyone. So I am an oral pathologist. Usually when I look for the lesions, but I have other kind of like interests that I work at NIH. So I work on conditions that they are autoimmune conditions and see patients for that too. But when Neelam came and talked about this study, I got very excited. I said that, okay, let's see how we can make this one a little bit magnified. It seems that I need my glasses times. Let's see, I just magnified on my, I left my glasses there, sorry. Okay, I tried to read it, so I have to probably squint a little bit. So we have seen at NIH 35 individuals so far, and also we have collected 125 samples. I see patients whenever I can go to the FA camp, and we have seen 6 patients or individuals at the FA camp, and also collected 22 samples. Okay, that's great. Also in the meeting, whenever I can come, so I see patients here, that it was really my pleasure. I wanted to thank all of you for coming here. I have done 103 biopsies. Among the biopsies that we have done, when I see a lesion that looks suspicious, I also do this either incisional biopsy or plunge biopsies. I have done 5 of them, and among all the individuals that we have seen, 3 individuals either with a dysplasia or malignant cells. What do we do when you guys come to the NIH? So we do the inspection of the mouth, so that's the first thing that we do. We do the documentation, and then brush biopsies, and we send all the samples to the cytology. So our cytopathologists read that one, and then we send the slides to the DNA plot. I just wanted to show you a couple of things that it might be a little bit overwhelming, but I try to kind of like make it as simple as possible. So whenever I look at the mouth, so we are looking at the normal tissue first. Everyone has a normal tissue. So it's good to always check your mouth so you know that this is normal. And whatever doesn't look like that, so then we call it abnormal. So the first part, which is the mucosa, it looks usually pink. Sometimes you see white lesion in your mouth. So the white lesion, usually we call it leukoplakia. So leukoplakia has a very kind of like, it's more like a pre-malignancy. So that's a reason that we wanted to catch it at that time. Leukoplakia can go from if you look at the second part, that's a leukoplakia. And then it can be mild, moderate, and severe dysplasia. So that's the one that Annika kind of like explained it very well as well too. So we wanted to capture most of the lesion in that spectrum. So you see on a kind of like one of them, the second one, you see that it's a white really lesion on the top. On a fourth column, you see it's a very verrucous and kind of like we call it granular in kind of like a pathology that sometimes is bumpy. So that's a part that whenever we do the biopsy, sometimes we see that it's a moderate to severe dysplasia. If the lesion looks like a red and white, that's a part that we call it erythroleukoplakia. So it's a white and red lesion together. A lot of lesions at that time, they either are severe dysplasia, or sometimes even it can be a carcinoma in situ. And then we have erythroplakia, which is the lesion is completely red. So let's see a couple of examples. So to see that what we are looking when we are examining. So the first column, you see that it's a small lesion on the lateral tongue. It's not very easy to see it, but if you look at it carefully, you can find it. So that's a part that I like to capture it. So, and then the lower one, I thought that, okay, so when we do the biopsy, how does it look like? So it's good to know that what we are looking at it. So the first part, it looks like the top part is completely normal. So that's a part that we see in other patients as well too. But when we go from the top to bottom, that's a part that we start seeing the changes, that we call it mild dysplasia. The second one, you see that the lesion is a little bit bigger, it's wider. For lesions that I'm showing to you, it's a lateral tongue, and I mean that in the side of the tongue. So we see more changes on cells. So that's a type that we call it moderate dysplasia. It means that the half a lesion has some changes in it. And then we go to the next one, which is severe dysplasia. You see that the lesion is bigger, so you might kind of like feel that, oh, this is not really normal. The fourth one, it looks really thicker lesion, granular, so we call it carcinoma in situ. And then the last one that we see that it's on a gingiva, it looks very different, it looks very worrisome. That's a time that is a carcinoma. That's a time that there is no basically reverse. So this is just what we do. So I do the brush biopsy, the brush looks like that, and we use the medium in order to fix the tissue and we send it to the pathology. So I just wanted to show you a couple of examples that some of you might be in the meeting in the morning and have seen that one. This is an individual that had a lesion on a lateral tongue. You see that this is small. If you look at it, some of you might miss it. You say that, oh, there's nothing. My tongue looks very normal. But this was a very subtle changes. So when we did the cytology, it came back as a negative for the malignant cell. A year after, I followed the individual and then again did the cytology, but this time it came back as a rare atypical cells. So that's something that I think a lot of you probably have a question. What is the atypical cells? Do I have to be worried about it or not? And I think in the morning, Anna had a very good kind of like a conversation about that one. That do I need to worry and follow up, or what do I do? If atypical cells, it's just being reactive, and I see a lot of inflammation there, I usually say that I still follow that one, but I'm not as worried. But if the atypical cells doesn't have that much inflammation in it, and it's not caused by any other reason, for example, sharp tooth or anything like that, then I wanted to follow up that lesion very closely to see that, what is the progression. And if it's necessary, I like to do the punch biopsy for it as well too. So then we followed in 15 months, and again we did the cytology. It came back as an atypical squamous cells suspicious for dysplasia. That was the time we did the punch biopsy, and it came back as a atypical, which is kind of like a moderate dysplasia. But there was an ulcer there as well too. But there was an area, a very small area, that made us suspicious that this is the carcinoma. So we referred an individual to a head and neck surgeon, so did the excision of the lesion. The second one is the similar kind of like a case as well too. So we saw a lesion on the gum, and cytology showed atypical squamous cells. So at that time, we did the excision as well too. It came back as a moderate dysplasia. Then the next visit, which was in 6 months, again cytology was done, and it came back as an atypical squamous, so it didn't change as much. And then the treatment was the laser abrasion. Laser abrasion is a good treatment, actually. I like it in a way that if it's not carcinoma, it can remove the dysplasia. And then on a next visit, which was done in a year, so there was no lesion, so we didn't do any biopsy. And then in 18 months after that, so there is no obvious lesion on a buccal, but when I look at the inside of the mouth, I saw a little bit of the kind of like ulceration there. So we did the cytology, and then we saw atypical cells. And then we did at the same time punch biopsy as well too. We saw well differentiated squamous cell carcinoma. Then there was a surgery, they kind of like removed the area that it was concerning, and the person is being followed up. So when we do the histology, what do we look at it? So I just thought that it's fun to see that what does the histology looks like when we are talking about it. This is the one that, you see some of the debris. I You see some of the area that, looks very kind of like a dirty. That's a part that there are debris. You see this part that, kind of like it catches our eyes. Some of the cells that they're like that, they're normal. So that's perfect. So we see normal cells a lot. And then this is the one catches our eyes. So it looks like a nucleus are big, so it's worrisome. We said that, okay, let's kind of like a follow-up. And the same thing that, in this case. So this is the one, it's a small one, but we have to look at the slides very carefully and to see that we can find it or not. And then when we see the lesion, so we do the cytopathology, we send it to the DNA pleury, and then after that we do the mutational profiling as well too, with the collaboration. This is very highly collaborative study. So at the NIH team has pediatric oncologists, it's me, and there is a cytopathologist as well too. So we do collaboration with the BC cancer team that they have a dentist and pathologist, and the German teams that you guys know them very well. In the team we have a pathologist that I don't think that came to the meeting, but and then we have a pediatric oncologist. And the Rockefeller teams, I think you guys all know them too. There is an oncologist and a molecular biologist as well too. This is just a takeaway that I wanted to tell you. So patient with the FA, so we know that there are at the high risk of the developing early onset of the squamous cell carcinoma. Then what is important? Routine exam. And then when you look at the lesions, not all the benign looking lesions sometimes are truly benign. So we just wanted to keep that one in mind. I don't want to scare anyone, but it's something that we have to keep it in mind. Clinical appearance sometimes can be misleading. So exfoliating cytology helps, which is to identify dysplastic cells. Then histology can confirm the cytopathology. These are sometimes kind of like a hand-to-hand. The summary is that this is, as I mentioned, it's a very highly collaborative study. We share samples and we try to do the standardization and validation of the brush biopsy, cytology, DNA cytometry, to diagnose precancer and cancer cells. The clinical assessment worked closely with the patient and their home provider. I think this was the slide that Neelam was supposed to talk, but I will maybe go through it. And then providers can do molecular sequencing from the tumor tissue. We do have a FCF tumor board discussion whenever we have any diagnosis of the cancer for comprehensive treatment planning. We have the Fanconi associated neurological syndrome collaboration with the neurology team. And as you know, we have a psychological assessment through the screening related to the distress study. And this is the team that you all know, and we have intramural collaboration and extramural collaboration with the British Columbia Cancer Center, Rockefeller, and Düsseldorf, Germany. Does anyone have any questions about? Perfect.
In our country, Denmark, they talk about dysplasia. Well, they used to talk about dysplasia as mild, moderate, and severe. But now my NCA has been talking about the possibility of jumping directly from mild dysplasia and then straight to oral cancers. So they're kind of blurring the lines. And I just wanted to know if you could talk a little bit about that.
So this is actually a discussion that we always have in our oral pathology meetings. So it depends on where you go and what you do and what kind of like a clinician you talk. The oral pathology community here, they like to have a kind of like a separation. So mild, moderate, and so the way that we do it, it's kind of like it depends on the thickness of the tissue, that how much of it is involved. That's a way that we characterize the mild to moderate. Dermatopathology, they change it. So I know that they have either mild and severe. So they remove the moderate from the equation. So, but we still here, we have a mild, moderate, and severe. Which severe, sometimes it can go very quickly to the carcinoma in situ because the full thickness of the tissue is involved. It doesn't matter in a sense that how you identify it, because at the end they're all considered as a pregnancy. But yes, some places I know
Patients get blindsided by it. It says mild, and it's not that important.
That's That's correct. Some of them, the mild one, so it's not that you have to ignore it, but I think you need a completely close follow-up, because that's a part that sometimes it can reverse. That's a part that we were talking, that you can reverse it. But when you go to the moderate to the severe dysplasia, I had a little bit hard time to say that you can reverse it 100%. So you can contain it in that stage, but it doesn't go completely to the normal.
We talked about our study and what it is. There are several people who have come to NIH, and there are 2 patient advocates who would like to talk to you about their experience of coming to NIH. And after that, I think if we have time, we should have some time so that we'll open it for everyone so that you can ask questions if you have anything that we can answer. Okay, I invite Michelle, Catherine de los Santos to talk about their experience.
I was exercising.
Be careful, Dr. Giri, we need you. Hi, my name's Michelle. This year will be my 3rd year going to NIH. I'll be going down there to see them in about 2 weeks. How it works, because I get a lot of questions on, how's it work, what do you do? They pack a lot in the 3 days you're there, but it's for our benefit. And you'll get your schedule, so you'll see, kind of know what your schedule's going to be like, so you can plan accordingly. When I went, and I've been through all the testing and stuff, one of the things they found with me, with the DEXA scan that they did, I have osteoporosis, which I never even dreamed that I could have. So they do find things. And the nice thing about that is the collaboration they have with your physicians. At the end of the 3 days, whatever test results are back, they sit down and talk to you. They go over all those results, and you'll have them. You'll be put into like a little portal where you live. You probably have your own, like my chart. They have their own, and you'll have all those results, and you can bring them back to your doctors, which my doctors love. Every time I go to my doctors, they're like, "What's NIH thing?" Make sure they know, so in case they have any questions. It's a positive thing. As an FA adult, and especially ones who have cancer, you get poked and prodded all the time, and it does get boring and redundant. But this is, to me, I get excited when I go, because this is for my own good. It's an extra group of eyes double checking our body, and it just helps. It's another group, another set, and it helps me to live longer and help, and that's how I see it. So I'm very grateful for them.
My name is Catherine. I also go by Kat, and I wanted to talk about this. Big advocate for this. Very, very big advocate. Bone marrow transplant when I was 8 years old, and ever since then I had a pretty good outcome of it. So I didn't really kind of go to the doctors for things that were wrong. I kind of just did it for management, and I became very, I wouldn't say obsessed, but I was a pretty good person, self-advocate for my own health. And I would go to doctors, and I would just make sure, and it just got to a point as an adult where it just was scattered all over the place. I had so many doctors, and from Atlanta, and I was at Emory. So I have all these Emory doctors, but I didn't have one center or one doctor that I felt like could really connect all the pieces. And I started looking into FA stuff on their website, because I went to my head and neck doctor, and they're high risk of cancer, and I'm hearing as an adult now all this cancer word. And I was like, well, I need more information. So I went on the website, and I was just looking, and this was summer of 2023. I would always get a lesion on the left side of my tongue, it would come and go for years. I mean, I probably had this for 10 years. And I was on the website, and it just happened to show up. It was they were just starting the study. And I was like, well, maybe I qualify for this. So I called, I did the questionnaire, super easy. And I was like, we'll see, I can get plugged in, because finally there's a study where they'll have everything in one place. It's comprehensive, and we'll see what happens. So I was talking to them, and I was like, hey, I've been having a lot of problems swallowing, and it hurts when I eat. And they're like, that's very concerning. Let's see as soon as we can get you up here. I was like, okay. At that time, I had just started graduate school, and I was like, we'll wait until December. So that was literally in July. And I'll go up there, and we'll get everything done. Well, in August, I had an endoscopy by my GI doctor to see why I was having difficulties eating. And at that time, the C word really scared me. So I was like, oh, I'm not going to do anything with it can't be cancer. And I had my endoscopy in August, and it came back negative for cancer. Fine, there's nothing wrong. But the pain got so severe that by November, I stopped eating completely. If it was on a liquid, I would not eat it. I would cry. It was horrible. So when I flew up there for December, they did everything, and I had a doctor. It was Dr. Garcia, one of the resident doctors, and she sat there for 45 minutes. I mean, at this point, it was 5 o'clock. And she sat there and she listened as I cried, and I really advocated about how much pain I was in and how this was unbearable and I could not eat or do anything this way. And she's like, don't worry, like, we're gonna get you endoscopy in the morning and we're gonna see what we find. And surely enough, they did that. They did a biopsy, and 2 weeks later, it came back positive for cancer. And they diagnosed me with esophageal cancer. So I originally was there for just follow-up and just preventative care for a lesion, and I ended up getting a cancer diagnosis. Now, what I did find out is, had I waited any longer, my outcome would be very, very different. I know for a fact that this study saved my life when it did. I did not know that I had to be looking for this, and they found it. My biggest thing is, as an FA adult, you need experts in this. And as much as I can go to Emory and I can see these doctors that kind of see things, they kept dismissing it. They were like, you're 28 years old, you're not gonna have esophageal cancer, you don't really meet the parameters, although they did have a little bit of information about this type of cancer that they were looking for. I love this study because these are FA experts. Like, they know exactly what they're looking for in the smallest and earliest stages, and I cannot advocate anymore for that. I know it is scary, it is a lot. You take in a lot of information all at once. I do recommend taking a support person with you to kind of help navigate and kind of lessen the load. I took my fiance, he's not my fiance, but at the time we were dating. And after these appointments, we would see the city. I mean, we were in Washington, so we would go to DC and take the train. And I try to make an experience out of it every single time I go over there and just kind of enjoy the setting and things I can control. But I think the best part also is at the end of the week, you get the comprehensive study. So I don't have to go home and leave not knowing like what happened. You know, a lot of these appointments, you'll go, you'll get tested, but you will get the results before you leave. Obviously, if they send out some like biopsies and stuff, that might take a little longer to come back. But I do love how comprehensive it is and how they're just so passionate. I mean, this saved my life. So every day that I can talk to somebody and try to get them to just sign up for this, I absolutely recommend it. And hopefully they don't find anything, and that's great. I think one thing that FA community has that a lot of the other communities of cancer don't have is that early detection and prevention, how much we just continue to like hammer on that. So if anything, if you are not part of the study, I would definitely look into it and just sign up for this. So thank you.
Just wanted to find out, I think I did ask this question on the last time that I heard about the NIH study. It's not open to international patients, right?
We open the study for everyone, only we cannot bring international patients, we cannot pay to bring international patients, but we do have some international patients who have come to US. When they come to US, they let us know in advance, and then we arrange for their visit.
So for instance, if we had to come down annually for this meeting, it would be suitable if we came through for the study?
So people have to sign up for the study in advance and let us know way in advance, because there are a lot of patients on the study who have been scheduled for clinic visits. So if we know way in advance, then that can be planned.
Thank you.
Yeah.
You talked about the DEXA scan. Are FA patients more prone to osteoporosis, and is it mostly women because of the early menopause, or men need to be checking that too?
That's a very good question, thank you. So one of the reasons is because of the hormonal imbalance and because of ovarian failure, there is an increased risk. And in men also it's the same thing. So we do DEXA scan on women and men. Yeah, that's part of the FA recommendation, and it is there in the FA guidelines for both men and women.
And then one more, when you're doing the liver ultrasound, what are you looking
for? We are looking for any changes in the liver, like fatty liver, called steatosis or anything else. And we also do what is called liver fibroscan that detects any stiffness in the liver. And generally, you might hear a lecture from Dr. Parinda Mehta, I think it's tomorrow. So a lot of people with FA have abnormalities in their liver function studies. We really don't know 100% what is causing these abnormalities, because a lot of them have both transplanted and non-transplanted individuals. So when we do fibroscan and liver ultrasound, we correlate those changes. There's something term called metabolic associated liver problems, MSALD now. So if the changes are quite significant, then our hepatologist recommends liver biopsy because that's one of the things they are following to see what are these changes, are these consistent in individuals and what can be done to reduce the progression. So one of the concerns is there are some individuals who have developed liver cancer in later ages. So we do these studies to learn if there are any early changes that can lead us to what is happening can be prevented.
Thank you so much.
I'm curious to know for a patient that has previously undergone a DEXA scan, if they just do it on a certain portion of the body, say for instance like just the femur, and they detect osteoporosis, does that mean that it's widespread? Or does the DEXA scan that you perform there at the Institute do like a head to toe?
We do whole body. It's femur, the femur neck, the whole femur, the femur neck, the femur head, spine, and also the forearm. So they do it.
Thank you.
I'm curious about the esophageal exam that you had. Remember your name? So I'm curious, like, why was it that it wasn't found at the first institution was at NIH? Was it that it was a different scan that they did, or was it just experience?
They experienced. It was missed twice. I had a esophageal biopsy, so I always get biopsied, so I had several in August, and I had another one in September, and they found it in December. They were looking at the wrong thing. I get dilated, and they just missed it. They were not biopsying the area where the cancer actually was. And that's what one of the nurses had explained over the phone was, if they're not biopsying the area where the cancer is, it's going to get missed every single time.
So not to get too specific, everybody, but I'm curious, doctor, if my son also has a debilitation, and they have said in the last few years that abnormalities, they biopsy that day, they biopsy. They're curious, is this something that we can get in to be seen with your team? He's not 17 yet. Does he qualify to be seen?
The study is open for people who are 12 years and older, actually from 8 years onward, if they have any issues. And I mentioned that most of the people who have come to NIH are 18 years and older. That's because most of the symptoms develop in young adults. But we do have people who have come at a younger age because if someone has any issues and has difficulty swallowing and are developing symptoms at a younger age, then yes, we would see them earlier. And if they have been evaluated elsewhere, then we would love to look at the records and discuss that, and also if needed, review the biopsies at NIH. Yeah, we can do that.
I'll add to that really quickly. So I had issues then after I got these results, going back to Emory and starting the process. And she called them every day, like literally her and the team were calling every single day for like a month to be like, okay, are you guys tumor board? Like, we have to do this tumor board. And they're like, oh, we don't need that. Like, we do esophageal cancer all the time. Like, we don't need to talk to the tumor board. And we just kept both, like, it was literally me and Dr. Giri were just calling them every single day, being like, yes, we do. We need a tumor board. We need this. We need this. And that kind of changed a little bit. I don't think it changed necessarily the regimen that I was going to do. I did both chemo and radiation, so it didn't change necessarily that, but it did give more insight and more knowledge and statistics and things like that as to how to handle it, even my post-care.
And that's what I like about them, because they are such big advocates for us. They're there to help us talk to our doctors and push to what we need, and that's what I love about that. So not only that they help us with the screening, but they help us make our doctors understand. And if for some reason they don't want to understand or they're not willing to listen, then they are there to help us find somebody who will listen and take care of us.
We have one more question.
She can talk, so I do it for her. In the Netherlands, we are told that FA patients cannot have chemotherapy and radiance. So, and you said you had chemo and...
Yeah, so for esophageal cancer specifically, mine, again, could have been different if it was found at the beginning of that year or when it was in August. I think we hadn't talked about that a lot, but the way I kind of understood it from my oncologist was that if for the type of cancer specifically that I did in the stage that it was caught, the best outcome would have been chemo and radiation. So having known that myself, I did prevention and I did what was in my power. So I exercised a lot, I ate a lot of good food, I drank a lot of water, and I got good sleep, and I prayed about it, and I said, God, it's in your hands. So I did everything that was in my power, and then I went through treatment, and It was very brutal, but to this day, the doctor who treated me said that I was one of the best patient outcomes that he has seen.
With your question regarding radiation not being given to people with FA, I think that's why if tumor board is very important. It has been very helpful for us to plan treatment because people who have received stem cell transplantation, if the treatment that they need to receive involves radiation, then there are radiation oncologists who suggest how it should be started and titrated and increased. So that has been really very, very helpful in both chemotherapy, radiation therapy, extensive surgery that is needed because none of us know everything.
Yeah, and just a plug for the Virtual Tumor Board, it is available to international patients. You don't have to be in the US. Anybody can reach out to the VTB for help with that, and we've talked about patients all over the world. So don't ever think that's not here or that you don't have to be part of the NIH study. It's available to anybody. And I know this is super important, but we need to wrap up. So Jordan's gonna give us a few announcements.